I'd like to introduce Erin Isenhardt, who obtained her doctorate in physical therapy at the University of Pittsburgh. She continued her career with UPMC to further her expertise in vestibular and concussion rehab. She's a board-certified neurologic clinical specialist and received her vestibular competency at Emory. Erin's work at Stanford Healthcare includes establishing vestibular rehab with the Stanford Concussion Clinic and collaborating with physical therapy at Packard and Stanford University. I'd like to welcome Erin. Thank you.
Well, thank you very much for having me here today. Very excited to talk about the vestibular side of rehab. As you heard mentioned earlier today, we have a lot of connections with vestibular and ocular motor with regards to post-concussion. So I'm hoping to at least show you a little bit more about what a vestibular physical therapist would do and the types of treatments that are involved with it. So when we think about the vestibular system, we think about dizziness. And with dizziness, it can involve an impairment of the vestibular system, but also the ocular motor system. And we've already shown that it has a common factor after concussion and may lead to delayed recovery. Happens about half of our concussed athletes and leads to a 6.4 times greater risk of that protracted recovery. Research has shown that the combination between vestibular rehab as well as cervical rehab will decrease that medical clearance for returning to sport and does have a positive effect on the functional dynamic visual acuity, as well as their dizziness sensations, nausea, and their balance and gait dynamics. So here are the typical symptoms that we think about with vestibular issues. And usually when patients think about dizziness, they actually think about vertigo. But what I try to explain to them is that I'm looking for like a fuzzy, weird, off sensation that they're feeling in their head. And then with vertigo is when the room's actually spinning in those circles, or internally you're feeling like you're spinning in circles. A lot of these patients have difficulty with visually complex backgrounds, like the funky carpeting in some stores, grocery stores. Visual motion also is very difficult for these folks, going to like an Omnimax theater. Think about visual motion also when you're seated in a car, watching things go by. They can get nauseous, also have some imbalances, and they can also describe just kind of a lag in their vision. When they're moving quickly side to side, they feel like they can't keep focus on these objects. So some of the causes that are dealt with dizziness involves the peripheral vestibular system, the central as well, ocular motor, and then we also think about the neck and autonomic intolerance. So just to briefly review the anatomy. When we think about the system, we think about motion perception, spatial orientation, head and eye coordination, as well as the balance and posture. And of course, it's sitting in our labyrinth right next to the cochlea. We have our 3 semicircular canals, which are collecting information about angular acceleration, and the otoliths, which are talking about the utricle and the saccule, that will take the gravity, linear acceleration concepts as tilt as well. And of course, all that information goes to the vestibular nerve, to the vestibular nuclei, which it has further connections with the cerebellum, the vestibulospinal tract, as well as the ocular motor nucleus. And this is just a more detailed description of that. But when we think about the vestibulospinal tract, we're actually thinking about, being able to control that head motion, control that trunk motion with that balance. There's also the vestibular cortex, which helps us orient ourselves with space, knowing what our personal space is too. And here's a video. Oh, that's not playing. There we go. So this talks about like the push-pull mechanism with the vestibular ocular reflex. When we're rotating our head to one side, we're activating one part of the vestibular system, and then the other part's being inhibited. And of course, that connection has to go to the visual system to keep focus on those objects. So when I do a vestibular evaluation, of course, we're going to look at the cervical spine. We know it's associated with concussion with the whiplash. We also know that can lead to prolonged headaches post-concussion. And when we think about the cervical afferents, all of them combined are actually kind of minimal in compared to those vestibular and vision and afferent inputs. But the thing is, it's about that mismatch of communication. So you're going to have that sensation of dizziness and disequilibrium when you have different things coming from the visual, vestibular, as well as the cervical spine. And also, treatment for that cervical spine has demonstrated improvements with cervicogenic dizziness. So in my evaluation, I want to make sure that everything's okay with the ligaments. So I'll do a Sharps Purser test, which is shown up on the top part of the scale there. So that gentleman speaking was talking about the C2 kicks test. We're looking at the alar ligament as well as the odontoid integrity. And we also look at the vertebral artery testing. This is usually done with the infrared goggles when they're having the fixation blocked. We'll have the patient rotate their head as far as they can and count backwards from 10, looking for dysarthria, pupillary changes, nystagmus to indicate something going on with the integrity of that vertebral artery. Another thing that we want to take a look at is their proprioception, and this is done by Rob Landell. Our rehab aide was kind enough to be the patient, and I'm not sure if you can see on there, but he's got a laser on his head, seated about 90 centimeters from the wall. And we have that target placed so when he's seated with a neutral position, it's completely in the center. The patient will close their eyes, rotate to the all full range of motion, and then come back to center and hopefully land on that target. But if you can see, his first trial, he didn't even get near the target. So we give them chance to learn and utilize that proprioception to find center. So we want to make sure they get about 3 consistent findings to be like, okay, you're normal or abnormal. I mean, if it's completely off the wall multiple times, we know that we're not getting anywhere near that center. It's a little bit of a time-consuming test because we're not only going to look at rotation bilaterally, you want to look at flexion, extension, as well as side bending too. And when we're thinking about treatments associated with the cervical spine, doing vestibular rehab, I can't do everything, but we know some really great orthopedic physical therapists up at the Redwood City office. We can work on suboccipital release, some manual traction. Want to work on strengthening their posture and their core because that's really important for that vestibular system to work properly as well as the visual system. And then down below, there's one example on how to practice that proprioception utilizing the laser on the head. So we got a little maze that you can go around. You can practice going slow and accurate, try to work on speed, have them start in a seated position, maybe have them stand, maybe have them on a squishy stuff or a Bosu ball. So always be creative and thinking, well, let's start with the simple stuff. Can they get that accomplished and how can we advance it further? Infrared goggles are key for a vestibular therapist. As I mentioned earlier, we're going to have that fixation block with the vertebral artery test, but we use it for many other tests, which I'll be showing you shortly. With the infrared goggles, we're able to get more eye movements to tell us more, is there peripheral involvement in addition to that concussion? And that's one of my main things when I'm seeing the patients prior to Dr. Gajar. Some of the ocular motor problems that patients will describe, which I know we've kind of talked about a little bit, is difficulty reading. And of course, when they say that, you want to investigate further. Is it more the concentration piece of this? Or are we talking about visual blurriness, visual fatigue, frontal eye headaches, difficulty being on the computer for longer periods of time? And in regards to the pathophysiology, as mentioned, we're not really sure exactly what the patho is, but we do know that we're seeing impairments with smooth pursuits, as well as saccades, near-point convergence, and exacerbation of symptoms with the optokinetic stimulation, which again, that visual motion. And vision therapy has been shown to help alleviate those symptoms after a concussion. So as a vestibular therapist, I have some of that in my repertoire, which you'll see with the Brock string and the smile push-ups here. But reality is, if this isn't working, we need to send them to somebody that only does vision therapy. So in my evaluation, I'm taking a look at the smooth pursuits with the IR goggles with fixation, so I can see the eyes much more clearly. Also look at saccades, near-point convergence, accommodation, and then of course ocular alignment, doing the cover and uncover test. And up on the top, the Brock string, you can have small strings or large strings. This is kind of a smaller one, so you can hold it with both hands. But again, focusing on that very close speed, middle, and then last speed. And then on the last one down here, the smile push-ups, because I write the word smile on there, coming in and out, trying to keep that in focus. When I'm looking at a nystagmus, we're thinking about spontaneous nystagmus that's evaluated in the seated position, in the primary position, which is looking straight ahead. And then, of course, we're going to look at the gaze evoked, which is 30 degrees from that primary position. So I look at this not only in the room light, but also with fixation blocked. And if I'm trying to decide if there's a peripheral involvement and I'm seeing nystagmus when the fixation is blocked, I want to see, is it peripheral by using Alexander's law? So in this patient right here, we're looking at their right eye, and it's demonstrating a left beating nystagmus. So if he looks towards the left side, it'll increase that intensity of the nystagmus. And if the patient looks away from the nystagmus towards the right, you should notice a decrease in that intensity. So that helps with that decision making. Also, we're looking to see if there's downbeating nystagmus or upbeating nystagmus, of course, indicating central findings. But we can also see convergent spasms with fixation being blocked, where unknowingly the patient will go into convergence and they'll usually describe some dizziness, some nausea, or they just don't feel normal. And that's associated with anxiety with these folks. The head thrust test is another way that I help decide if there's a peripheral involvement or not. Whenever you're moving the head quickly to one direction, so with this lady, we're going towards the left, we're testing the left side. And as you see her eyes deviate from the therapist's nose and then comes back, that's a positive indication. So when we're looking at this, trying to find out if there's a peripheral involvement, it's going to help key us to send to the otoneurologist, Dr. Steenerson, who will be talking to us later today. Another thing to look at is the head shaking nystagmus test. Again, the patient's head is shook quickly 20 times, and we're looking to see if there's any nystagmus at the end. When we see nystagmus here, the slow phase is what's indicating the potential. Yes, go ahead.
Who's doing the shaking?
The therapist is, so it's passive, yeah. And so with this right here, you're seeing a right beating nystagmus, which would indicate the left inner ear being involved. So we talked about VOMs a little bit, and the vestibular therapist always is doing the assessment of VOR as well in the testing. And here I have Kara, who is an old therapist of ours, doing this at 180 beats per minute, which is what's required for the VOMs. We're looking to see if that patient can keep focus on the target as well as keep the coordination and seeing if there's dizziness, headache, nausea associated with this. Another thing we look at is VOR cancellation. If you look at the VOMs, it says visual motion sensitivity test. It's the exact same thing. And what we're looking at, of course, is the patient able to keep focus on the object. So down below, if it's abnormal, you'll see those saccades with going back and forth. And in a normal individual, you should not be seeing that. A lot of these patients will describe dizziness and nausea, so of course we're going to work on this for their treatment. Another thing to look at is that dynamic visual acuity. So we have a demonstration out there by our university therapists, but we have the Logmar chart just because it has the same number of letters on each line instead of the typical like E and then it adds 2 letters, 3 letters. So you want to get baseline first and then shaking their head at 2 hertz. And we're seeing how close to that baseline we can get. If you lose 2 lines, it's considered normal. More than that is abnormal. And of course, with these patients, a lot of times we do get normal DVA, but they're symptomatic. So of course, we still want to work on this type of movement. Anything in this evaluation that's provoking any type of symptom, we're going to focus on in our treatment sessions. As mentioned earlier about the VOMs, here is the scoring of it. And the purpose of it is just to have a brief tool for post-concussion after a sports-related concussion. So you don't have to be a vestibular therapist to be able to do this. As mentioned a little bit ago, I'm looking at the eye movements, but here we're just looking at the symptoms. The only true measurements are done by the near point convergence to see how well those eyes can come in together. With regards to the VOMs, it has been validated with internal consistency and sensitivity, and it's also shown that the vertical VOR and VMS, which is everything moving together, can be symptomatic 8 to 14 days after that concussion. And also, a recent pilot study was looking at King-Devick testing, and it was showing that the VMS and near-point convergence can significantly predict the KD testing time to be lengthier. So let's talk about treatments. So I would invite everybody to pick a target on the wall, and I'm going to put my metronome on to 180 beats per minute and move their head back and forth. This is really fast. Not only we're trying doing it horizontally, but also vertically as well. It's important to have baselines on these patients because mentioned earlier, you're going to have some dizziness with people at baseline. So if we get a concussion and then we do it again, we're not really sure, is this who you really are or is this because of the concussion? So up on the top left, she's just looking at the target. And of course, we start in the seated position. If they can't handle that kind of speed, we go way slower and then slowly progress. And an advanced version of it on the top right and bottom is VOR times 2. So we're engaging the pursuit as well as the gaze stabilization. Starting seating, going to standing, walking forwards, walking backwards, standing on squishy stuff, keep advancing that. When we talk about visual motion sensitivity, again, taking that VOR cancellation, use it as an exercise. So you go side to side, up and down, diagonals, seated, standing, walking, treadmill, whatever you want to throw at it. Here's the ball toss. Same kind of idea as just looking and holding it, but you have a target that you're not holding. So again, trying to follow it with your head motion as well as your eye motion, walking forwards and backwards. I love the YouTube videos. So grocery stores are very troublesome for these patients. And so we can have them actually just sit on their computer and watch somebody walk to the grocery store. There are more fun things with people on like BMX bikes, going over hills and jumps. Down below, you can take a medicine ball so we can think about strengthening the core as well and moving slowly as these people are demonstrating, but then kind of moving faster to really challenge that system. And here at Stanford, the Neuroscience Health Center, we have some fun equipment. So on the left-hand side, we have the bits. And so you can start, of course, seated or standing, but I have Janae on the Bosu ball to make it more challenging. We have the rotation on the left, but there's numbers from 1 to 50, so she has to try to find them as quickly as she can. And then the next one I kind of call whack-a-mole, so you're trying to find the target and hit it as fast as you can. As mentioned earlier about using the grocery store for YouTube, you can actually stand on the Burtec, which I'll be showing you in a minute, and there is a grocery store simulation, and you can make it easy, slower, less stuff on the walls, but while you're in there, you can just see if they can tolerate being in there. You can have them look at the targets on the side to side, tell them to name the things that you see, so you have some optokinetic stimulation as well. And then just straight up optokinetics, it can be variable in speed, in size of the lines, in direction of the lines. Again, training that response. And BPPV, most people are well aware of it. It happens about 5% of the population with sports concussion, so it's not very common, but it's something we want to be aware of. And here's a lovely demonstration of my son doing the Dix-Hall-Pike test, which I could not help but take a photograph of, and he's doing the right-sided Dix-Hall-Pike. Posterior canal is the most common, so that's what I have demonstrated here. And again, just showing the eyes, the type of nystagmus you're expecting to see with a right Dix-Hall-Pike, that rotation upwards. And if we're going to do treatment, the Epley Maneuver would be utilized. With this one, of course, rotate the head, roll aside, and sit up. You can do it once and be done, but you can go up to 4 times in one session if you need to, depending upon what their presentation is like. But a lot of these folks can have just difficulty with being in those dependent positions, nothing to do with the crystals. So we do positional habituation exercises for that as well, where they practice laying down, sitting up in bed, rolling from side to side as well. So let's talk about the balance system for a little bit. We're going to look at sensory organization. So it's the brain's ability to collect information from somatosensory, vestibular, as well as the ocular motor system, or visual system. And the brain organizes all that information and tells our body how to react appropriately within our environment. So balance strategies, we think of the tiering system of the ankle strategy being the most efficient. And then we're utilizing our hip and then stepping strategy as well. And we also know that with sensory organization deficits, it can lead to poor balance after concussion and lead to more injury, risk of injury. So the modified sit-sib is a little bit easier version, but the sports concussion folks are most used to using the best test, which are doing floor and matted, eyes closed on all these conditions, feet together, tandem, as well as single leg stance. As mentioned earlier, we have the Burtec at the Neuroscience Health Center, and there we have the ability to put the harness on them so they can feel safe. But on the right-hand side is actually what that test looks like with the 6 different conditions. So we're doing eyes open, just how do they feel being in this environment, eyes closed. Number 3 is when the walls are moving or that image is moving. And then 4, 5, and 6, same idea, but the floor is moving. And it's sway reference, so they're really in control of that movement. If they're moving, that floor is moving. We also want to take a look at dynamic testing too. So we think about the functional gait assessment. And it's not perfect for our sports people. We're actually in the midst of trying to find a new way to do a dynamic balance test for our sports individuals that's more related to what they do. But right here, it looks at walking, looking side to side, looking up and down with walking, eyes closed gait, quick turn and stop, changing your speed, stepping over objects. And of course, we want to look at their gait speed, because a lot of times when people are dizzy and off balance, they want to walk really slow. So we want to, of course, improve their gait speed, which also helps with their balance as well. And again, more treatments. If they're having troubles with sensory organization, we practice it. So start simple on the floor, go over the basics of what center of gravity is, how to utilize your somatosensory system to keep your center of gravity. And once you get through the basics, then we try to progress to different areas on the blue Eric's phone, the squishy stuff there with the Bosu ball, eyes open, eyes closed, head rotations, get that vestibular system involved. Throw them on that treadmill, have them walk forward, backwards, different speeds, head rotations, have them do gait stabilization, ball tosses, have them cognitively engaged as well, making them think of animals that begin with letter A, B, C, and D, and so forth. And then, of course, the functional tasks are the most important. When you think about doing dishes and doing the laundry, that's all vestibularly engaged. So we want them to practice that as an exercise. So I always tell patients, instead of going in and grabbing as much as you can out of that laundry machine, get one piece and intentionally try to move yourself more to integrate that vestibular system as an exercise. Going to the grocery store, use that as an exercise. If they're off of work or, of course, with our sports concussions, they're still in school. If they're not going to school at the time, make them go to the grocery store every single day and engage in that environment. In regards to patient expectations, I think this is one of the big things that are really important to talk about with these individuals. You want to make sure they understand, what is this vestibular system? Why am I working on this? And how is it really going to help me? And why am I going to make myself dizzy to feel better? And reality is, we're not really trying to make them so dizzy. It's all about what each individual can tolerate. So if we start off with one of those things like being on the treadmill doing gait stabilization, their brain's going to go haywire, and they're going to feel horrible for days afterwards, have anxiety associated with it, and not want to come back and work with me again. So we really have to deal with the patient conversationally each time that they come in to make sure, hey, how did this program go for you? And if they said they were dizzy for hours after doing the program, well, it's too hard, back off. We're trying to stimulate the brain and stimulate the system, but with intolerable means. And that means different for different individuals. I also want to make sure that I educate them on how the anxiety system works with the migraine system and the vestibular sensations. Because everybody thinks that there's something wrong with them, but reality is that vestibular and anxiety centers are moving together. So when you have that dizziness, we're activating the anxiety, and vice versa with the headaches as well. So really educating them and letting them know that this is part of the issue really helps them buy into the therapy and do the exercises with me. And of course, this is a multidisciplinary approach, especially with these patients that have longer symptoms. We want to make sure that we're engaging the psychological therapies as well as cognitive with speech-language pathology and occupational therapy. We mentioned exertion as well, which Dr. Limba Brown did a wonderful job talking about. And she also mentioned how the university student or the university physical therapists engage the vestibular system, which yes, you need to. You start slow, eliminate everything, wear hats, sunglasses, earplugs, whatever you do to get that stimulation out, and start on that recumbent bike. But as you're progressing and moving forward, you want to engage that vestibular system to be able to do what's required for that sport. Occupational therapy is wonderful as well. Not only can they help with that visual system with functional tasks, but they also do something that I love, which is called the adult sensory profile. So these patients have difficulty with lights, with sounds, vestibular engagement, visual engagement, and they have a hard time dealing with it. So this sensory profile enables them to write down what areas they have issues with, and the OT can help them figure out how to cope with those issues of stimulation better. And of course, if people are having difficulty with return to driving, they do driving assessments as well. And then with our speech therapists, they can look at attention, memory, organization, as well as problem solving. And the big thing too is executive function. So we do have our neuropsychologists that can do those testings that can help us guide to our speech language pathologists as well. And thank you, appreciate it.